Welcome to Talk About Pain. And today I have with me Beth Ann. She is a licensed physical therapist with 19 years of clinical experience. Her vocation has spanned from working with individuals who have eating disorders to those in the intensive care units at level 1 trauma centers. She now focuses her practice on women's pelvic health, physical therapy integrated with a holistic perspective. Her website is www.wombmatters.com. That's WOMBMATTERS.com. Beth Ann enjoys working with women who experience a variety of pelvic health issues such as optimal natural fertility, painful and irregular periods, incontinence, leaking, prolapse, endometriosis, abdominal scar-related issues, postpartum issues, and the perimenopausal transition. Her physical therapy practice is unique in that she focuses her work on integrating research-based pelvic health physical therapy with optimizing organ mobility, digestion, pelvic circulation, and energetic flow to address a variety of symptoms faced by, sorry, I'll cut this and do it again. It's
No
a long
worries.
sentence.
I'm famous for those.
Yeah. Her physical therapy practice is unique in that she focuses her work on integrating research-based pelvic health physical therapy with optimizing organ mobility, digestion, pelvic circulation, and energetic flow to address a variety of symptoms faced by women, informed by research and complemented by her training in holistic pelvic care, Arvigo techniques of Maya abdominal therapy, lymphatic circulation therapies, and gentle visceral osteopathic manual therapies. She has also completed training in research-based health coaching as a women's health coach through the Integrative Women's Health Institute. Beth Ann recently co-created and taught a holistic pelvic health curriculum with a somatic psychotherapist, which they call the Conscious Pelvis Practitioner Training Program. It introduces pelvic health to a variety of professionals who are interested in caring for the female pelvic body and story with a nervous system-centric, trauma-informed, and energy-sensitive lens to support optimal pelvic health on all levels. Beth Ann, thank you for joining us.
Thank you.
That was a mouthful.
Yes, it was.
You've been busy.
I've been busy.
Yeah.
For a while. Yeah.
So I'm just curious, what got you started with pelvic health issues?
Yeah, I did. Meaning my own story. I did, as you mentioned there in the bio, I did mostly intensive care unit physical therapy for the first 15 years in hospital-based PT work. And that I affectionately say now that had an expiration date, and it was 15 years. And so at that time, I took a break from the profession for almost 2 years. And during that time was becoming more kind of focused on my own story, as is, I think, common sometimes as we head toward midlife, like what's happening with my body, my pelvis, the rest of me, and where do I need some attention? I think we can be, we're caregivers, and so we can be very over-focused, perhaps, for a lot of reasons on others before our body often calls us back to ourselves. And so I had some pelvic health things myself and decided to start enlisting the help of various professionals to work on that. And for a while, I thought I wasn't going to come back to PT. And as I went through a discernment process, decided, you know what, I have a license and the opportunity to help people, and I'm not done yet. And so went and did and continued to do a bunch of education to pivot in this way. And here I am 3 years, formally 3 years into my practice. So yeah, it was my own body experience.
I think that's interesting to me that you distinguish what you were exploring with your pelvic health issues from PT, as if the two weren't already part of the same thing. What was that? What was your thinking about that?
That's a fascinating question. there's a professional bio and there's a personal bio. And I think that often when I think about what's happening in my own body, I think I want to cut this.
That's okay.
That's such a good question. Let me start again.
Sorry, I didn't send you the prep question because
no, I love
that
it.
just came out in what you said.
Yeah, I assumed if you could do me a favor and ask the question again, I do want to answer it because I think it's important.
Yeah. So I think what's interesting about what you just said is that you separated yourself as a PT from what was going on with your pelvic health. Why was that separation there in your mind, and what did you do about it?
Yeah, that is a bigger question. I think there's a lot of cultural reasons that I wasn't focused on my own pelvic health. There's some academic reasons. When I came into the profession out of school, and I actually went back to look at this, my kinesiology professor in PT school was pretty well known academically and had published the next big textbook that all the schools were going to use. And I love him. He's an amazing teacher still. But I went back and looked in the text and like, there is nothing on the pelvis in here. It was just kind of a big black hole. We didn't even learn pelvic floor muscles or anything like that. So there was a paucity of education initially. So I was like, well, I don't know what's going on with my own pelvis. I guess it's an OB thing and it seems kind of mysterious. And I was also, brought up to think that things like dysmenorrhea or painful periods were just normal. And I thought, well, if this is normal, I guess I'm just supposed to grin and bear it. And something shifted in that time to say, hey, actually, this isn't normal. And there are things that can happen. And when I put my PT hat on, again, with particularly the issue for me, one of a few issues around dysmenorrhea or painful periods, I realized, I'm a PT. I wonder if there are some things that are in my wheelhouse or things that I could learn that are a part of movement, manual therapy, working with myself, nutrition, that I could apply to my experience. So once the kind of misplaced normalization was put in the box of like, hey, actually you can feel better, Beth Ann, I started kind of going down that path of like, not trying not to pathologize myself, but to kind of put it in that proper realm of actually this isn't a normal experience. And once I labeled it as that, I could do something about it from an empowered place. Does that make sense?
Yeah. It's so interesting how sometimes our training can get in the way of what maybe our vision of what it is that we should be doing is. Yeah. I'm curious. So let's clarify what exactly we're talking about here. When you're talking about pelvic health, what is pelvic health?
Yeah, I think there are two ways to answer this question. Because one thing to know about me, and I think you know this about me already, Rick, is that I don't think straight from A to B. I'm kind of all over the place. And so let's just say that maybe for your listeners, the easy answer is anything that has to do with bowel, with bladder, with sex, sometimes also with digestion, is kind of in the realm of pelvic health. That said, there's a whole nervous system attached. There's a whole body attached. There are stories that live in the tissues, in my experience. There's a input, a fuel or a nutrition story attached. And so pelvic health, I think, helps maybe the general public to understand that, hey, this thing does exist and we can help you with bowel and bladder and digestion and painful intercourse and things like that. But it's also a spectrum. So we have amazing people, I think like yourself, who actually treat people with pelvises, because we all have them, and who help people to resolve pelvic health issues that may not hang their shingle out as a pelvic health PT or OT or whatever. And then there are those who are in pelvic health and are kind of myopically focused on just the pelvis. So I like to try to live somewhere in the middle, like this is a whole person, and biomechanics from the shoulder may be a part of what's happening with the pelvis or the neck, headaches, that kind of thing. So that's the less straightforward answer, is that pelvic health is kind of a part of all the health. And there are whispers throughout the body that might offer us ideas about what's happening in the pelvis if we're looking kind of beyond just the space, around the hip area and everything in between there.
So based on that, it sounds like pelvic health is not only for women, but for men too.
That's correct. And I appreciate that you mentioned that. While my practice is focused on the women anatomical, understanding, and I work with some very kind of particular to female body issues, absolutely. I believe male pelvic health is the most underdiagnosed, undertreated, under everything of all the parts of physical therapy or rehab that we're aware of. And I have some amazing people I refer to when it's needed. But yes, men have a pelvis and therefore have challenges with incontinence or pain in the scrotum, issues around defecation and things that impact them that can also be helped by a physical therapist or an OT or someone in pelvic health.
Okay.
Yeah.
You mentioned before, you made the comment, and also I think it was in your bio, about stories that live in the tissue. Can you speak a little bit more about that?
Yeah. Stories that live in the tissues. I humbly submit that this is an incomplete understanding for me. And if I had it all figured out, I wouldn't have enough time to treat everybody. But I think it goes back to the nervous system. So I know the nervous system is kind of having its heyday, and for good reason. I like to say in my practice, the nervous system is queen. And again, that's important, because when we look at the pelvic tissues, one factor as far as the story in the body goes is that tension is an output of the brain, in my understanding. Muscles are only messengers. So if tension is an output of the brain and it signifies some real or perceived threat that may be happening in a system, there's a story behind that that may be as individual as the person that I'm working with. And so, at least for right now, I'm always evolving. Year to year, some people come back and they're like, oh, you're doing this now. I'm like, yeah, I'm always learning and evolving. But that's my understanding right now. And so understanding the story of the person on the table helps me to understand the tension patterns that might be inputting to the system and holding someone, for instance, who has pelvic floor muscles that at their baseline have what I call, I don't like to use the word hypertonic and hypotonic, it's very pathologizing, but I'll call it like the baseline resting tension may be elevated or decreased. And so there are stories that input to those, and those stories may be biomechanical stories. They may be, what are the repetitive patterns or shapes that someone assumes with their body that are most common. They may be biochemical. Sometimes I work with a colleague who I'm doing some mentoring around kind of tissue health and mast cell activity, in particular mast cell overactivity as a neuroimmune output. And so sometimes tissues that are too inflamed can't respond well. They stay in tension patterns because there's just too much overactivity in the immune system. Or it might be trauma. It might be that someone had an experience, but it doesn't necessarily have to be. We think of the pelvis and we always associate sexual trauma. And while that's true, and I don't want to minimize that, any kind of, falling off a horse or going over the handlebars on one's bike or any of these things, because the pelvic floor musculature and fascia and all the structures are such an anchor point for the body, that it can be one of the first places that tension patterns show up, and often perhaps one of the last places that we can help someone to work out that tension pattern, so to speak.
Yeah, I'm on board with you all the way with that. You know, our brain as the driver of tension patterns in our bodies. And, you know, I'm just thinking right now, you know, I have a fear of heights, and anytime I walk near a ledge, I can feel it in my pelvis,
Yeah,
that fear. And it's just not a very comfortable feeling. So
totally.
I absolutely get that connection and understand what you're saying there. I'm curious, you know, you've mentioned a few professionals uh, with regards to pelvic health, like PTs, OTs, doctors. Who is the best type of health practitioner to diagnose a pelvic health problem?
Mm.
How does that work?
Whew. Yeah, I like that question. It's funny that I had the response that I did because I think it depends on the problem. Um, my observation in pelvic health, so I spent 1 year very early in my career in sports medicine outside of the hospital, and it was at a time when we had master's degrees and doctors were starting to recognize that if it's movement dysfunction, a PT probably knows better than I do what's happening here. Um, and so they just write shoulder pain right on the script and leave it to you, the PT, to figure out what's exactly happening in this whole thing. And so I'm seeing that to some extent now in pelvic health, um, you know, pain, or, and I don't actually get a lot of my referrals from physicians, so I don't see it directly in that way. At this point, it's changed a lot. But people will come in with, I feel pain here, or I experience itching, which can sometimes be a nervous system thing, or what have you. And the onus is often on me to figure out what are the drivers to that pain. And so if there's an obvious, the long way to answer that, if there's an obvious skin issue in, let's just say, the perineum or the vulvar area or something like this, that may absolutely drive increased resting tension in the pelvic floor. And then we have kind of a weird cycle, and I need my OB-gynecologist or urogynecologist colleagues to help me deal with the skin issue so that we can break that tension cycle. So in that case, they're the best ones. In another case, if it's, you know, urinary incontinence, you know, the official medical diagnosis is usually going to come from a urogynecologist. I'm a big fan of those specialists, in particular in my practice, because they do have a good diagnostic skill set. But we're even learning things about some of the diagnoses that they offer. And no offense to them as colleagues, they have so much to do and so much to figure out with people. But even things like maybe some of your listeners have heard of interstitial cystitis, which we think is a bladder thing, but the vast majority of people who have that, and it's like there's a lot of bladder urgency and frequency and itching and pain in the bladder area. For a lot of folks, the driver in that is elevated resting pelvic floor muscle tension pattern. And because the bladder is a neighbor, it becomes very angry, but it's actually not the bladder that's the primary problem. So they might come in with a diagnosis from the urologist of IC, but what it really is we need to break the cycle. And I'm seeing actually it's maybe not IC, it's truly an angry bladder that needs some relaxation and release from these pelvic floor muscles that are really tight. So as a PT, of course, I cannot officially make a medical diagnosis, and I want to make that clear. But when we think of the real root cause of something, who is the best person? Boy, it really depends on the situation. And having a clinician, a PT, OT, whomever, who can parse that out, it's something I'm always working on. Is this something I can affect and take care of? Do I need another member on the team? Is there someone more effective? Do we need to collaborate? Those questions are always going on the first couple sessions that I see someone.
Mm-hmm. Yeah, I guess it's a lot like other areas of the body. If there's an obvious cause, then it's easy to figure out who the best practitioner should be. However, if that's not so obvious, it's good to have a few people in your wheelhouse.
It is.
So, you know, is your type, is your type of specialty on the radar of other medical professionals that, hey, if there's something that's not responding the way have you reached out to these people? Are they aware of practitioners like yourself, typically the gynecologist or the uro?
Yeah, I think they're aware in pockets. It's very individually professional dependent. Like, hey, I can work with IC, and in fact, as it's formally called interstitial cystitis still, which we're actually switching to calling it painful bladder syndrome. Understanding that most of it's driven by the pelvic floor. The Urology Society or whatever of America, I'm not good with all the proper titles, but they've identified pelvic floor PT as the second line treatment. But the urologists are not, as a group, and talking to my other colleagues in this space, referring to PT like as one of the first things they do, or at all. So there is somewhat of a disconnect. The big one too, postpartum women, I think, while I'm biased, most will benefit from having some kind of a PT assessment. And in fact, that's a standard of care in many other countries who have access to PT for postpartum care. But it's not here. Generally, if I see some OB-gynecologists who are like totally on board, and midwives are a group that are actually really attuned to postpartum physical therapy, but it's not consistent. I'm not sure that it's not clear that it's in the education consistently for those professionals to consider PT as an early helpful strategy for folks.
Yeah, I think it brings up this kind of idea that I learned early in my career, that the medical professional that someone is seeing really is the gatekeeper for their treatment. And if that medical professional isn't aware of another professional such as you or me or whomever, then that may be beneficial to that patient, then that patient misses out because the gatekeeper isn't aware. And I think it's really important for patients to take, I think they have, unfortunately, in today's society, the patient has to take more responsibility for asking questions and doing some searching, and not solely let the medical professional be the gatekeeper to ask questions of your doctor or PT, or, hey, do you know of a pelvic floor specialist, or a physical therapist or OT or whatever that I might be able to see? Can I get a script for that?
Right.
I think it seems to be something that people need to ask for in many cases.
I very much agree with you in that. It is a question of advocacy for oneself, which admittedly, our system is not set up for that. I think there's some shifting going on because people are finding that they need to ask for the care that they need. And I think there are pluses and minuses to having access to Google, to get some language. I'm not a Google shamer or a Google exclaimer. It just is what it is. And it can give someone some language around, hey, like, people are doing these programs online with pelvic health, PT, or rehab. Like, I can rehab. I don't need to be leaking all the time, I learned. And I read that a PT can help me with this. What do you know about that? I think it's a matter of empowerment of the individual. I very much agree with you, and minding our status as gatekeepers, and having it on our radar to always be expanding our ability to know who's around us that can support our patients is so important. It's impossible, of course, to know everyone and everything, but it is you remind me of how wise it is to have a variety of professionals to draw from so that patients get the best care, because so many situations, it's not necessary to potentially suffer as long as they do.
So what Is there a type of person or patient that would typically suffer from a pelvic health issue? Maybe someone who has been pregnant versus someone who is not, or an age or something like that?
Yeah, it's such a good question. And I would have to say that like type is like what type of personality or what type of comorbidities they have, or have they had babies. Pelvic health was largely born out of a lot of female orthopedic PTs getting curious about what was happening in their own bodies after having children. I contend as I got into pelvic health and have a passion for those who haven't had babies and have a lot of pain. I have a passion for working with people who experience pain related to endometriosis, and that's 10% of the world population. That's 1 in 10 people who are in female bodies. And so that population, to sort of say, oh, I don't think we can any longer say postpartum women benefit the most from pelvic health. I don't think we can stay there. And so, any of those issues. And then perimenopause is a big one. And I've gained a keen interest as I enter that phase myself, to understand that the tissues change because the hormones change, and tissue integrity is highly dependent on what's happening in the hormone kind of milieu of the body. And so I also think that whether or not they've had children, women who are entering that perimenopausal phase have a huge benefit as well. And again, types of people, men who have had, I think I don't know a ton about this because I don't treat it, but I do know enough to say that every man who's had a prostatectomy should be referred to a pelvic health PT who can work with that, because there is some evidence emerging that they can help some of the function for if they're having issues with urination, or if they're having issues with intimacy with their partner or that kind of thing. Pelvic health PT can be really helpful for that, but a lot of men don't know that. So it's hard to pinpoint. I guess no, there's not a type of person. There are people in lots of groups who would benefit.
Yeah. Okay. You mentioned that hormones have an effect on tissue integrity. Can you elaborate
Sure.
a little bit? Yeah.
Yeah. So the place that this often comes up is with a woman who might be postpartum and breastfeeding in particular, because at that point the estrogen levels will be low. And we have enough evidence at this point to understand that one of the roles of estrogen, there's estrogen receptors throughout the body. It's not just a uterus ovary thing. And one of the places that's really estrogen sensitive is the vaginal wall tissues. And so when the estrogen is low, there's a potential for kind of a looseness in the tissue, because estrogen and collagen have a really tight interaction with each other. Estrogen helps to lay down collagen and elastin, these extracellular matrix, or these fibers that make our tissues kind of plump and have what I call good tension and support and that. And so with less estrogen, there's more kind of potential for more drag that some folks might experience, or more heaviness or less elasticity. So in perimenopause, that can be a big deal. Sometimes women who have never had symptoms of, for instance, pelvic organ prolapse, all of a sudden they hit perimenopause, their estrogen drops, and now they're feeling things, and they're wondering, why am I feeling this now? And often it's because of that estrogen change in their body. And again, like I said, with breastfeeding, which in that stage of the game, when someone is postpartum and breastfeeding, there's often, while we can do a lot in the PT realm with them, there's also kind of that window of, let's also see what happens once you're done breastfeeding, whenever you would choose to do that, because sometimes that return of estrogen can be the thing that they need to feel better in their body, depending on the issue.
Interesting. Okay.
Yeah.
Are there pelvic health issues that are often misdiagnosed, would you say?
Trying to think about my experience with that question. I would have to say that I don't have a lot of direct experience with kind of big misdiagnosis. I'm just not sure that it's always accurately diagnosed. So it's not like it's the wrong thing, but it's not maybe as right as it could be.
Mm-hmm.
I don't know if that makes sense.
What comes to mind is your example of the spastic bladder, maybe due to excessive tension in the pelvic floor muscles.
Sure. Right. So the driver or the root cause may not be the one that was suggested, even though that the symptom or what the person is feeling is absolutely spot on. So yeah, or understanding that even the evolution of pelvic health, we keep returning to this understanding about interstitial cystitis, which is always evolving to understand, like, hey, what we thought that was is not actually maybe for everyone. There is 10% that actually have lesions inside the bladder that do create it, make it more of a bladder-centric issue more than the pelvic floor muscles. But because we keep getting more research and understanding what's happening, it's a little bit of a moving target to understand, was this diagnosed accurately? Was it not? Do we just know more now than the person who had their thing diagnosed 10 years ago? We just didn't know that 10 years ago. There's a lot of factors, I think, in that.
Yeah. So I wanted to get into a little bit about the types of treatments you provide.
Sure.
So I have no clue. So, and after reading your bio, I realize even more strongly how clueless I am. So why don't you walk us through, like, how do you treat someone for a particular pelvic health issue? What does that look like?
Sure. Frankly and humbly, I will submit that some days I have no clue. I have the things I know. I have the things I'm continuing to learn, and I listen to some of the intuitions that might come up as well. I don't think that intuition is a bad thing. I think balanced with the evidence we have, it can be a really important tool for us. But part of the evolving story for me is that as a trauma-informed lens, I'm also working through the somatic experiencing curriculum with Peter Levine's work. I don't know if you know that. But I really, really believe this piece. And, in 10 years, we might be talking about something else. But right now, it seems that the nervous system is one of the central things. So I want to learn as much as I can about it. So for me, at this point, my practice is evolving into, where's the baseline nervous system? Is someone really sympathetically driven or more kind of hanging out in a fight or flight mode? Or are they overly parasympathetically driven and kind of in a collapse mode? Because so much autonomic, or what we would say is automatic function in the body, is in the pelvis. And, between bowel, bladder, intercourse, and what sits on top and into the pelvis is also digestion. I always tell my patients, those are the things we're not supposed to have to think about too much. So when they start occupying more of our conscious mind, we've got to look at that, and we've got to use a nervous system perspective. So I often start by looking at those things with people, looking at as much as I can with the vagus nerve function. That's a bit newer for me to understand. What are some of the ways that I can help people work with their vagus nerve? It's kind of the star nerve at this point, and I try not to think about it in isolation, because I think there's a lot more going on just than that. All the nerves in the body are important, but we start there, and then I'm also, again, trying to get a more full picture of the story. So an initial PT session with me does not look typical. And in fact, at this point, I don't I do examination, I do external. I'm also looking initially at the lymphatic system. I think it's a forgotten system, and I think it can be a driver in persistent pain for some folks. It certainly wasn't a part of my education. I don't know about you. I've been learning with some osteopaths recently, because I think for pelvic pain in particular, there's a lot of circulation and flow challenge happening in the pelvis, with regards to some of the things that I treat. And so I'm looking at nervous system, lymphatic system, and then once we've got a good picture of those things in the story, and we're working with the nervous system throughout, and also working honestly with a process of, I often need to help people restore consent and boundaries to their bodies, because a lot of female bodies in my practice have experienced large or small violation to their bodies at the hands of medical professionals. And that is a really low-hanging fruit, and by that I mean like really obvious reason that pelvic floor muscle tension persists. So I have to know that I'm getting a good picture of their pelvic floor muscle resting tension. Like, is it elevated because I'm just in there at the moment and they weren't ready for that? Or is it elevated because this is a part of what's happening for them, and how much? So my assessment and treatment, I kind of go back and forth or dance between assessment and treatment constantly, and really trying to walk down a path with someone at the pace that their body can handle and that the rest of them can handle, to work with that nervous system. Because honestly, what I have some people who come to me and say, I heard about pelvic health PT, I want to work with this, but I don't want the internal exam that I heard pelvic PTs do. And I say, great, maybe you don't need it at all. I mean, maybe in 10 years, no one will get it because we won't need to worry about it. I'm open to that too. Pelvic floor, we're trying to get away from calling ourselves pelvic floor physical therapists, because A, the pelvic muscles are not a floor, they're anything but. And B, muscles, like I said before, muscles are messengers. Is that do we need to poke at those first thing to understand what's happening with someone? I don't think so. So that sounds fluid, and I get it, because it is for me, and it's very individualized. No one in my practice gets the same self-care plan, which is my expression of home exercise program. It might be mindset and movement to start with. It might be something to work with their own manual therapy on their body. I'm a big fan of I do some manual therapy, but eventually I want you to do it for yourself. If it's something that seems like you need it consistently, I don't want someone to keep coming to me forever. So making sure someone feels empowered to touch their own body. Sometimes we have to hang out there for a while, because honestly, the abdomen and the pelvis are very vulnerable spaces for people, for a lot of good reasons. And so we start very slow, and it might just be kind of what's the nervous system doing when I touch my belly? So it looks really different depending on where the person is coming in.
Speaking of coming in, my son just came in. You probably heard that elephant that just came through the door. So
it was
my
almost
apologies
nothing.
for all the noise to anyone listening, but that was a great answer. And what I get, Beth Ann, is I really promote a systems-based evaluation rather than component thinking. Blaming one specific tissue as the cause. Sure. And it's talking to you, it very much sounds like really that's what your approach is too, is we have to go in thinking about all the systems, and maybe we have an examination, but that examination is touching the tendrils of all different parts of the web to see which one is talking to us,
Yeah.
I love that. I think you're thinking of a lot more things than I am when I'm going through my exam. So good for you to be able to keep all of that.
Sometimes I don't. Admittedly, it can be a little overwhelming. And, I keep trying to, honestly, I wrestle with the tension of having more of a protocol, because it would maybe help me. And there may be some looseness to a structure as it's emerging for me, as I learn more about some of these systems I didn't know about, like the lymphatic system. But it's like the body just, and I want to have integrity to what I do know and what we know about the body, and not just sort of airy-fairy kind of fly around doing random things and seeing what happens, right? So those are, again, two ends of a spectrum. But I think it lives somewhere in the middle, like what you said. I really like the way you articulated that.
Yeah, I just had I interviewed Dr. Shirley Sarman just a couple of
Oh,
weeks ago,
awesome.
and she was talking about in physical therapy, and I absolutely agree with this, that we're not taught a systems-based approach to things anymore. And so, you know, with all the physical therapists that come into my clinic, I have to train them on a comprehensive systemic exam, you know, and that's just like not something that's really on their radar at all. Because I think in PT school, and maybe I don't know about other medical professions in general, but in PT school, it seems that, and this is what she said, is that the focus is more on the type of treatment rather than understanding the condition. And to me, I know that that's the way it is. I just don't understand how that can be.
Sure.
How can you treat without knowing the condition?
Right.
But, you
Right.
know, yeah.
And it's interesting you say that, because I've always been, apologies to the phone in my office is usually silenced all the time. So sorry, it went off there. Because of my intensive care unit background, you just kind of emerged something for me. I've never been so much treatment oriented as were, let's just say, biomechanically oriented, kinesiologically oriented, as I have been physiologically oriented. So for me, I'm a little bit more of a physiology buff, and there were a lot more things that we had to understand about condition, because we didn't, this is the ICU, like not understanding enough of a person's condition and how they might respond to the activity interventions could get us in trouble. So there was a need for a deeper understanding. And I would say the fun thing about pelvic health, fun and helpful, is these ideas about what's happening with the hormones, or what's happening with mast cell activity in the neuroimmune system, which is what I often call it now, is that there is a need to understand, because applying movement or interventions, the goal is to help them last. And if there are other variables that are really kind of short-circuiting or creating a persistent obstacle for that, maybe it's a lymphatic congestion issue in the because someone has a left shoulder injury and all of the lower extremity lymph has to drain through the left shoulder on most people, then it's not going to help them shift into a different place. So I love that she said that. I'm honored to be interviewed alongside Dr. Shirley Simon, but it seems absolutely true.
Yeah. You just kind of delved into it a little bit with your discussion of the shoulder and the lymphatic system. What role would you say are people's daily movement habits or patterns? How do those daily habits relate to pelvic pain? Can you give some examples or?
Yeah, so many. I'm trying to grab a few out of the thought clouds.
Which ones?
So one that's coming up for me first is, for instance, constipation. So most people don't realize that a lot of pelvic health PTs treat constipation, and we have to, in order to deal with bladder issues. There's a strong correlation there. And constipation, it's multifactorial, but one of the big things is when things shifted into COVID life for people, so much less movement happened. A lot more folks were getting constipated. And so the movement interaction with the digestive system is huge. I'm also noticing a lot more in my own body as well as that of others. This has come up. We're so sagittally focused in our movement patterns, and the pelvis, lots of like weakness in the outside hip muscles because we're not spending time on one leg, working on our single leg balance. We're not spending time on all fours anymore. And that's actually one of the ways that I very easily have my women who are postpartum, depending on the stage they're at and what's going on, play with your baby on the floor in all fours, breathe, see how that feels. Like you're doing it already. Let's just do it with mindful attention. So what I'm actually trying to say, I think, is that I've seen a diminishment in the variability of movement that is deeply limiting our movement patterns, and it limits lymphatic flow. And if we're not using our shoulders, we're not getting the big lymphatic pumps in the shoulders to get the lymph back to the heart, and lymph holds on to inflammation. So if that's true, then like it's hanging out somewhere else in the body or in our brain or whatever. So that lack of movement overall and the lack of movement variability, I think, limits our range of motion, obviously limits our strength, limits our responsiveness, limits our resilience, our movement resilience, and our ability to be ready for things that maybe are spontaneous or what have you. I'm not sure if I got off track there a little bit, but yeah, the daily habits are so important. And even for higher level athletes, I don't work with a ton of them. I think my practice is geared a little bit differently. That being said, the repetition of movement in very familiar patterns can be just as much a problem as the person who doesn't move at all in different ways. They might have better cardiovascular, cardiorespiratory function, but they can have just as many issues with their pelvis because they're also lacking a movement variability that affects different systems.
So I'm curious, Beth Ann, so can pelvic asymmetry contribute then to pelvic health issues? For instance, if one ilium is rotated forward or back or what have you, is that something that you look at as causative, or is it or not? I really don't know.
I don't know with you. The truth be told, I don't know what role it plays. I check it on some people. I sometimes do some muscle energy techniques, although that's newer for me, just to try things with different people to see what happens. I think you might be aware there's a lot of debate about that and about our special tests as physical therapists, and if they're actually telling us what we think they're telling us. I am not a person to hang my hat on a biomechanical asymmetry and call it good. So I think when you come into the territory that the story is key and the story in the nervous system is key. I mean, I've seen people with terrible looking posture or habits that have no pain. And yet other folks who, when they change their posture, and there's some things we know about some pelvic health conditions like pelvic organ prolapse and such, where, working with the different diaphragms of the body and having some alignment of those things can diminish pressures and create some benefit for folks. So I humbly submit that I don't entirely know, but I'm not willing to say to a patient, hey, your right hip bone, your right ASIS is a centimeter lower than your left. That's why you're in pain. I will not do it. I don't think it's beneficial for that person's long-term healing of whatever is going on with them. And I'm just not even sure that it's right because of all we know about pain neuroscience. Yeah,
I asked that kind of as a follow-up to my movement question, because while we see a lot, those kinds of asymmetries in the body, they're very easily corrected because they're due to movement dysfunction.
Sure.
And so, that was the connection. I was wondering, Because if a movement dysfunction is creating a pelvic asymmetry, and that pelvic asymmetry is contributing to pelvic health pain or dysfunction of some sort, then ultimately the movement is causing or contributing to the pelvic health dysfunction.
Yes.
So
Okay.
I just wasn't sure. I don't deal with pelvic health issues. I don't see patients for that per se, but I do see a lot of pelvic pain people,
Right.
that I wouldn't have thought of as pelvic health, but because that pain resolves with biomechanical correction, I'm assuming it's not a pelvic health issue. I really don't know. It's a gray area for me. I don't know.
I have always thought of you as the best movement oriented, and I know you have a lot of you've done a lot with Shirley Sarman's work, and I'm still trying to I didn't come into pelvic health from orthopedics or having a ton of big movement background after being in the hospital for so long. So I'll be perfectly honest that is where I need to strengthen some things in my practice. And so yes, it's always yes and for me. Yes, I agree with that. And my experience is sort of split. So it's tricky. Is there one way for people to improve? Are there different ways? Some people need a top-down approach and other people need a bottom-up approach. And there's someone for everyone. And we do know that a movement systems kind of approach works. I know you've had tremendous success with your folks. We also know I can't find the study for you, but 95% of women who have, and I may be flipping this, so it's okay that it's going on to a podcast, but 95% of women who have low back pain have pelvic floor muscle dysfunction, which I'm sure doesn't surprise you because it's a part of the whole package.
Yeah.
So I don't know what you're asking in your intake or as you go along with folks, but I wouldn't be surprised if you put on some of your pelvic pain people's radar, hey, did you have incontinence, or was intercourse with your partner painful, or whatever? If they get better with that, I wouldn't be surprised, because I don't think an internal exam, and I think it's good and it's important and it's the work that I do, and a lot of people, I use it more for awareness and reconnection, less so than maybe some of the other things that it was originally taught to us for, but it's not the be all end all. So I'm sure that you're helping a lot of people with pelvic floor dysfunction related issues without even knowing it, because they just didn't know they were having that along, it's part of the package, I guess.
Yeah, I don't know, but we both seem to, because tension is a big driver. I'm a big, I like solving tension-based problems, and sounds like you do too. I guess there's a lot of cross-pollination that's happening between our approaches.
I love it.
So, yeah. Can you speak a little bit more towards, how menopause may affect pelvic health?
Yeah, I'm still learning a ton about this myself. So we mentioned the estrogen issue earlier on, and that's not the only thing, but it is a major factor in how women feel different in their bodies. Because I work with period pain as well, and kind of organ or uterine focused issues, one of the things that people will see me for as well is they might have a fibroid that they're not ready to have surgically removed because they don't want surgery, even though it's been advised, or they have it's very common to have menorrhagia or excessive bleeding as one enters menopause because of the shift in the hormonal levels. And I would admit that our work as PTs with that is somewhat limited, but there may be some circulation and stagnation issues that go with that can be worked with abdominal therapy. Also, just the exercise, the really great thing that we do as PTs is working with stress management and exercise. And I know that sounds kind of fundamental, but so much of stress management. So in menopause, the adrenal glands, we lose estrogen from the uterus and ovaries predominantly. But what's supposed to happen is that the adrenal glands create a type of estrogen that then gets converted so that the tissues that still need that can have it in the post-menopausal phase. But for so many women, their adrenals are spent when they hit perimenopause or kind of on that menopausal line. So they're not getting that bit of estrogen that their body still wants in that phase. And that can contribute to a myriad of issues. One of the big questions, of course, is always like, why do I have this belly? You know, why am I getting this menopause belly? And I think as PTs, we could speak to, again, the stress piece of that. There is some correlation between what I just explained and how the excess cortisol level preferentially lays down some of the adipose tissues in that part of the belly. Although I know that's kind of the magic thing that everyone's always trying to like explain and figure out. And a lot of women are really active and that still happens. So then it's like, we have to look at Carolyn Van Dyken. I don't know if you know her, but she's someone who I've been learning from recently, is very big on the biopsychosocial approach up in Canada. And she talks a lot about, you know, working in as well as working out. So sometimes if that piece is developing for someone, the belly, they just think, well, I need to exercise more and do more and burn more calories. When in fact, it might be more stress related. And we might need to look at how are you sleeping at night, because sleep becomes a problem for a lot of women in that time because of night sweats or, you know, all these different hot flashes and these kinds of things. And so if we can't sleep, we can't heal for sure. And we're not going to have normal healthy hormone release. So that does become a part of our realm very readily, is how is sleep happening? Is a meditation, are you the kind of person that would gravitate toward meditation? And would that be helpful to help with the stress piece? And if you're not, like, what's another kind of activity? You know, where's the helping people find their joy, I think is a part of what we do, honestly. And sometimes in that transition in menopause, it's for many cultures, it's a rite of initiation, and we don't have that in our culture. So I think a lot of women in our culture in that phase feel kind of lost and ungrounded. And I think lots of our body strategies and movement strategies can support women in finding that sense of new purpose, regrounding, that kind of thing. And I know that gets a little more esoteric, but I think it's an important conversation. So the more physiologic things beyond that are escaping me at the moment, but the drop in estrogen is real and it can have a lot of effects, not to mention cardiovascular changes for bones, getting women to be more active with their bone health, and you know, Wolf's Law is always happening. So, you know, if they're big swimmers, helping them to see that it might be important to do some walking or even you know, any other weight bearing activity as they move forward to help protect their bones is probably important.
All right, good answer. At the other end of the spectrum, are there public health issues of affecting puberty that at that time that arise because of puberty?
Yeah, and I would honestly say that I'm not sure I can speak to this with the male body in mind, because I've spent a lot more time looking at it with a female body lens and through the female body perspective. But I would say a big one is periods. It's really important that the education change and shift, and the ACOG, the American College of Obstetricians and Gynecologists, produced a white paper in 2015 saying that at the onset of menses or starting to have a menstrual cycle for women or for female bodies, it is considered a vital sign. It's considered a really important part of their health. And so the state of the period, the state of ovulation, the state of menstruation is a way that we know what might be happening in the milieu of the body. The challenge is that if a female has period pain from the get-go, there's kind of a disconnect between what they say in the white paper and what's happening in practice, because commonly what happens is that they're placed on birth control. And I'm not saying birth control is bad, but it does have pros and cons. And one of the pros is it does help to often diminish the pain in the period. But it doesn't touch anything on a root cause about why that pain was there. It could be endometriosis. It could be a primary dysmenorrhea issue that isn't endo. It could be, and I've seen this because I do a little more osteopathic type work, that, they're a really high level athlete and they have really tight uterosacral ligaments on both sides or one or the other. And that is affecting uterine mobility in such a way that they have more cramping around their period because they've taken some hard landings onto their tailbone or a myriad of other things that I've seen. So absolutely. And I know, I'm being a little more period focused or physiologically focused in my response. And for good reason. I'm not sure as a whole profession of pelvic PTs, rehab therapists, that we're as focused on period health as we should be, because it gives us really good information. So yes, is my answer. I get a little passionate about that one.
Well, that's why I'm talking to you, because I don't know. This is a big, area I don't know anything about, and I really respect what you've learned. Are you good on time so far?
Yes.
Okay, because I do. I mean, it's fascinating listening to you. I'm learning so much, so thank you.
Well, we can be done whenever you say. It's your podcast.
Well, I have another. What about, you've mentioned digestive system and visceral issues. What's that relationship to pelvic pain? What's going on there?
Yeah. So the way I explain this to patients, we talk about viscerosomatic and somatovisceral crosstalk, and all that. It's a really fancy way to say that nerves innervate muscles and organs. And so, especially when we get into the thoracic and lumbar nerves, where they come out from the spine and what they go to in the abdomen and pelvis, it behooves us, if there is a way, to have some interest and knowledge about what's happening with organs. And I will be clear that doctors of osteopathy can really talk about organs per se. As PTs, we're talking more about the fascial connections, or what holds the organs in place in the body. And that's a really complicated discussion too, because it's a mixture of turgor pressures and fascias and tension and a lot of things. But to simplify, organs and muscle, you might have in the osteopathic lens a kidney that's doing something funky, but it's creating quadratus lumborum spasm or tension. And if we keep treating that QL, it might get better. But if there's some kind of manual therapy that would help the kidney to have more space, maybe it's kind of stuck in the perirenal fascia or something, and that's more of the primary factor. The muscle's just telling us that there's a problem somewhere. It's not telling us that it is the problem. So, part of my expanding and sometimes maddening interest in learning more things is trying to understand, like, where else can this tension come from? And maybe I'm getting too complicated. I don't know. Maybe the muscle is always the way in, because it is the messenger. I can talk back to the muscle and it would take care of the organ issue. Probably need to talk to you more about that. But suffice to say, when we get to the uterus and the ovaries and that kind of thing, there can be ovarian-driven low back pain. And there's actually a great case study that was written about that in particular. Period pain that is predominantly in the back. Sometimes I see associated with a uterus that's flexed back rather than forward. And so when inflammation, which is natural, happens around the period, there is more potential fluid occupying the space, and it creates some pressure on the sacral nerve roots. So there's this kind of interplay between what's happening with the nerves, and then it might make someone feel like they have to urinate more or whatever around their period. All of these symptoms that seem really weird around our period, when we look at it through that lens, can make more sense. But they can absolutely be factors in pelvic health. So trying to look at it from both directions can be both, and the 500 other directions that I'm not aware of can be really helpful.
Yeah, that's the thing, isn't it? We're so interconnected, and everything
Yes,
is so interrelated.
it's true.
You know, I feel very limited in my understanding of how we're just aware that maybe that they exist, but how to work with them is a whole nother matter entirely.
It is. It's very humbling all the time.
Yeah.
I keep doing it because I want to help, and I do see that there are ways to help, and yet it's expansive. The body is expansive and knows way more about itself than we know about it. And so it's always humbling every time.
Yeah. Yeah. I guess that's why there's 1,000 books out there, about how to fix this or that, and 1,000 different ways of doing it,
That's right.
Yeah. Well, Beth Ann, I'm just, I've learned so much from you today, and I really appreciate you for, diving so deeply into this, what I think is a neglected area in physical therapy, but needed, So, I thank you for your time, and I love that you're still searching. I'm still searching. I think, how can you stop?
You can't.
Yeah,
It draws
yeah,
you in. Yeah.
yeah. So thank you very much, and I'll hopefully see you soon in person.
It would be fun, Rick.
Yeah,
Thank you for all that you do and for doing this and reaching people. I'm so
my
grateful.
pleasure.